Welcome. Welcome to the ERA's CKJ Journal Club. Each e-seminar takes place on the last Thursday of the month at 1700 Central European Time, which is 1600 time here in Oxford. It picks up a topic from the CKJ original research or review articles, and the author or authors will introduce their work. There'll be at least one expert on the panel, and today it will be moderated by CKJ Editor-in-Chief-elect, Professor Maria Sola, and myself, Will Herrington. I'm Oxford-based nephrologist and epidemiologist. And the discussion lasts for about an hour. It's fairly informal. We encourage live and hopefully lively questions from you, the listeners, typed into the Zoom Q&A box. It is recorded and will be made available on various social media platforms afterwards, so keep an eye out for links. And this month is our 9th CKJ e-seminar, and we're moving to transplantation. We're moving to the subject of post-transplant diabetes, and in particular the opportunities for novel therapeutics. Since 2008, the FDA mandated large-scale cardiovascular trials when testing new treatments for diabetes, and there's been a remarkable explosion of evidence on cardiovascular risk prevention and renal risk prevention from these novel strategies, as well as important safety data. And we would like to start seeing these utilized in transplant patients if they are safe and efficacious, but there is a lot of uncertainty, and certainly uncertainty myself was what brought me to Nuria Montero's review article. Nuria is the author of CKJ Review on the subject. She's from Barcelona in Spain, and I'm going to let you tell, she can tell us which hospital she's affiliated, because I apologize, I really can't pronounce it, and I don't want to humiliate myself or upset your hospital team. So welcome, Nuria.
Thank you.
And we have got expertise from Professor Sankar Navaneethan, who's an Associate Chief of Nephrology and Director of Clinical Research at that section in Baylor College of Medicine in the US. I know him as a systematic reviewer and meta-analyst. He was a working group member on the Cadigo guidelines for diabetes management and CKD. It's great to have his wide-ranging knowledge and evidence of the evidence base and to be available to us at the seminar today. So we're grateful for your time.
Thank you. It's a pleasure to be part of this.
Thank you for joining. Thank you. And so I'm looking forward to this. Nuria, we should just hand over straight to you and your presentation.
Okay, thank you very much. It's nice to be here, and I really want to thank the opportunity to share our work. So let me share my screen. Okay. So, good afternoon to everyone. I'm working in Belviche Hospital, and here is a review, a narrative review that we published 2 months ago, and it's about, as you said, management of post-transplant diabetes mellitus and opportunity for novel therapeutics. Those are my disclosures of interests. And then here you can see the index, the structure that I will follow during this presentation. I will start with a brief introduction. Then I'm going to explain 4 things about incretin agents, later about sodium glucose cotransport 2 inhibitors, and finally 3 conclusions. I will start with saying the importance of post-transplant diabetes mellitus. It's a really common problem after kidney transplantation, accounting for nearly 15% in high-risk patients. It's important to say that before 2013, it was called knee-onset diabetes after transplantation, but latterly the name changed, and now it's called post-transplant diabetes mellitus, which includes also diabetes pre-transplantation. So it's really important because if you sum diabetes and post-transplant diabetes mellitus, it's approximately 50% of kidney transplant that will require diabetic management. The pathophysiology is based on the impaired insulin release, and that's due some pre-transplant risk factors such as sex, male sex, obesity, or genetic background, also the age is related to have an increased risk or the hypertriglyceridemia. And then some transplant-related factors will induce even worse response to glucose control. And the known factors are surgery stress, viral infections, and also a really important problem is immunosuppression. That, as I have said at the now, gives a beta cell dysfunction, and then with impaired insulin release. It's also a problem of insulin-mediated glucose uptake in peripheral tissue. And also you have, these patients have a problem with the incretin axis. It doesn't work, and it produces inhibition of the insulin-mediated glucose production in the liver, and dysregulation of the appetite by the brain. Its clinical importance relies because it's an unquestionable risk factor for cardiovascular disease and chronic kidney disease in solid organ transplantation. And also diabetic nephropathy is found early after kidney transplant. So it's important to know this problem and also to treat it correctly. Post-transplant diabetes is also a costly condition that brings up to a 67% of increased risk of graft failure and 87% of increased risk of death due to premature cardiovascular disease, cardiovascular deaths, and also infections. And those horrible percentage and even worse when we are talking about recipients that had previous diabetes. So it's quite important to know that and try to treat it correctly. The therapeutic options, depending on the population, we're now talking about kidney transplant recipients. Cadigo guidelines have recently been published, and they only talk about the diabetes management in chronic kidney disease. And in these guidelines, they give a lot of emphasis on the newer antibiotic agents. And in fact, they put the first line therapy, metformin, plus some of these new anti-diabetic treatments. Unfortunately, in kidney transplant recipients, we don't have these guidelines because there's scarce literature now. We don't have enough evidence to make these unquestionable indications. In fact, in the early post-transplantation period, we use insulin analogs because it's a challenging condition with all time changing glomerular filtration rates, and these kidney transplant recipients really initial problems that can dysregulate their glucose and metabolic control. And we have another problem is that oral drugs such as metformins are generally not used because most of these patients have a reduced renal function, and then there's an increased risk for metabolic acidosis. So it seems really, and it is really necessary to evaluate and give guidance on diabetes management in kidney transplant recipients. So moving on, the second part of my talk, I will explain the mechanism of incretin agents. As you can see here, when you ingest any carbohydrate, there's a release of one hormone. In fact, the incretin axis is working, and there's one hormone, the glucose-like peptide 1, GLP-1, that has an important function. This hormone wants to lower the blood sugar levels. And how do they do that? By stimulating beta cell function, by inhibiting inappropriate post-meal glucagon secretion, suppressing hepatic glucose production. It also delays gastric emptying and also suppress central appetite. And all of this is just to don't have an hyperglycemia after in the ingestion of any carbohydrate. We have two molecules that can act in this axis, the GLP-1 receptor agonist and also the Dpp4 inhibitors. The Dpp4 is an enzyme that makes that GLP-1 become inactive. Here is just, I'm not going to extend a lot of that on that point because it's not about post-transplant kidney, post-transplant diabetes mellitus. It's only about general type 2 diabetes. It's that these agents have a really known effect on macroalbuminuria. You can see that there have been published a lot of meta-analyses. I've chosen this one with the most important clinical trials. As you can see here, the use of these agents makes that there's a lower incidence of new macroalbuminuria. It also lowers the incidence of major adverse cardiac events. It also has an important effect on lowering glycosylate and hemoglobin, and it also reduces body weight. So it seems that in type 2 diabetes, a very convenient treatment to use. But in terms of kidney transplant recipients, we have a problem is that we don't have enough data to see these effects. In fact, there are some studies that show, some studies it's very low with a low number of patients that show any effect on GFR or albuminuria. The same, we don't have enough evidence to know if it has any effect on cardiovascular disease, but yes, we can tell really sure that this agonism of the glucagon-like peptide 1 receptor increase the insulin secretion and decrease the glucagon secretion. So it obtains better glycemic control, and it also obtains a great weight loss. You can see this table in the article. I'm not going to explain it to you in detail. Just I would like to show you that there's not a lot of studies. They are of not very good studies. The most of them, as you can see here, are case series. There's only one retrospective cohort study and only one randomized control trial. And as you can see here, the agent more used is dulaglutide and liraglutide. And as you can see, most of the results are related with postprandial glucose control and weight reduction without any focus on cardiovascular disease or renal effects. So it seems that we don't know a lot of this in kidney transplant population. The adverse effects related to the use of these agents are headache, injection site pains, but in kidney transplant population, what is important are the mild gastrointestinal intolerance that produce nausea and reduce appetite. And that's important in kidney transplant recipients because it can potentially be worsened by concomitant use of mycophenolate, because mycophenolate intolerance is produced by the inhibition of replication of gastrointestinal epithelial cells that leads to this disruption of fluid absorption and then leads to diarrhea. In GLP-1 receptor agonists, the problem is mediated by the suppression of central appetite and the delay of gastric emptying. So it's a summatory effect and can be worse than the use of these two drugs together. Although it's all hypothesis, we don't have evidence on that. Transplantologists, we are always looking at the possible drug interactions with our immunosuppression therapy. We don't want to lose the graft, so we are always look at that. And as you can see here, it seems that we don't have any problem with calcineurin inhibitors. It's not clear if levels of mycophenolate can be modified because of this alteration of gastrointestinal motility, but it seems that they are safe agents to use in our population. Okay, I'm going to move on Dpp4 inhibitors now. And as I said, for the GLP-1 receptor agonists, first just a brief summary on what is published in general type 2 diabetes. As you can see here, the use of these agents in this meta-analysis is well shown that you don't have a significant change in urine albumin to creatinine ratio. And neither you find any effect with major adverse cardiac events. But what we know, and it's sure, it's that you have a benefit on glucose control with a better glycosylated hemoglobin reduction. So it seems that these agents mostly act by improving metabolic profile. In terms of kidney transplant, we don't have anything about cardiovascular benefits. There's some study that shows a decrease of albuminuria, although it's not really clear because most of the studies don't show data about that. And what we really know is that the same as the other agents, that the use of these Dpp4 inhibitors improve metabolic impact with decreasing insulin resistance and beta cell dysfunction, decreasing insulin requirements and obtaining a better glycemic control, and finally a little effect on weight loss. Here you have a table. It's really informative. Just I would like to show you here that another time we have low studies with low quality. They are case series of not a lot of number of patients. You can see 22 patients using linagliptin and sitagliptin. That's important to know because we won't have data about a lot of molecules. And what has been studied is the effect on reduction of glycosylated hemoglobin, as you can see here, that it's not very high. And what is really important, and we already know with type 2 diabetes, is that we don't find hypoglycemia with the use of these agents, what is really interesting for our kidney transplant recipients. Oops. And then the other part of studies, the randomized controlled trials, you can find 3 published, and all this data is about kidney transplant recipients. There are no studies in other solid organ transplantations, and also using sitagliptin or vildagliptin, and the same. You can see a modest effect on lowering glycosylated hemoglobin. And what's it's interesting in all this table is that with the use of Dpp4 inhibitors, you can see an increase of insulin secretion. So it could modulate and improve metabolic profile. These agents have few adverse effects, only rarely gastrointestinal intolerance, so are really easy to use and very comfortable to the patients and also for the clinician to start. And what is a really big problem for clinicians that work with kidney transplant, or you have to know to act, is that it can change calcineurin inhibitor levels and also mycophenolate mofetil levels, because it's a substrate of CYP3A4 and also a substrate of PGP. So the use of this, the initiation of this therapy can change immunosuppression levels. They can change that, so you have to control and make sure that you are on target after starting in these treatments. As you can see in the table, so we don't have a lot of studies. We only have studies looking at sitagliptin and saxagliptin. So the other molecules, it's not that they didn't interact. The problem is that we don't know. So probably they will. And finally, our last topic, the sodium glucose cotransporter 2 inhibitors. I'm not going to extend on the mechanism of action. You all know that they increase glucosuria with all the sodium reabsorption and modulation of the glomerular feedback and controlling glucose, blood glucose levels, and also controlling weight. It's known. And I would like to thank Will for this slide. Here you can see, as I've done with the other molecules, that the use of these agents is really interesting in terms of all nephrologists, because they and we have enough evidence to say that these molecules decrease the kidney disease progression. Here you can see a meta-analysis that includes a large number of, 3 randomized control trials with a large number of participants, 5,000 in each one. And as you can see here, the use of these molecules, not only in diabetic, but also in non-diabetes patients, can improve the heart failure rates and also kidney disease progression in patients diabetic and also in non-diabetic patients. In terms of kidney transplant, we don't know anything, and it's a field that I think that we will have evidence soon, probably because there are studies that are now being done. And as you can see here, we don't know anything about renal benefits. It seems, and some studies show that it could decrease the hyperfiltration. It seems that it will be the same as the non-transplant population. And it can also decrease albuminuria, but we really don't know. In terms of cardiovascular benefits, it seems that it can also improve the systolic blood pressure, but another time we don't have enough evidence. What it's very well demonstrated is that the use of these molecules can improve weight loss. And here you have the table that's published in the article. You can read in detail there. Another time, a lot of case series, but here you can see that there's one prospective interventional study and one randomized controlled trial using empagliflozin. And what you can see is that you improve metabolic control, you improve body weight, and what's the most interesting part is that it seems that there's a slight decrease in glomerular filtration rate, but it's maintained and it doesn't move more in 12 months of follow-up. And another important thing are adverse effects that is data based on studies of general type 2 diabetes. It's well known that if you increase glucosuria, you can more easily present urinary tract infections. And that's a really special problem, a relevant problem in kidney transplant population, because they are more vulnerable because of chronic immunosuppression and also because of the surgery and the functional and anatomical abnormalities because of the surgery. And not only because they are more vulnerable, but also the fact that UT can lead to deterioration of renal function and in worst cases, graft loss. So we have to be aware of this potential adverse effect, and we have to monitor them more closely than the general population. In general population, it seems that it's also more frequent genital mycotic infections and necrotizing fasciitis, but we don't have data about kidney transplant population. Another time, we have to be aware of the probable and possible drug interactions. Canagliflozin, that's the unique molecule that has been studied in terms of drug interaction. Is a weak P-gp inhibitor, so it can modulate and increase calcineurin inhibitor levels, and also mycophenolate or mTOR levels. So we have to be aware of that and monitor the levels of immunosuppression drugs while using these drugs. So I think I am on time. I will finish with 4 conclusions. In kidney transplant population, it's necessary to establish a broader therapeutic strategy to improve glucose control. And what I think it's most necessary is to generate evidence to safely use incretin agents and SGLT2 inhibitors, evaluating their role in terms of cardiovascular and renal benefits. And that's all.
So thank you so much, Nuria. There's compliments from the listeners. Thank you for a great talk. There's so much information from so many studies and those nice tables. There have been requests for you to share your slides. We've never had that before. So thank you. So maybe I could kick off with the first question. What do you treat people with when they get post-transplant diabetes a couple of years down the line? What's your drug of choice and why?
Well, it depends of glomerular filtration rate. It also depends on the patient, because if you are treating like a very old patient, perhaps you won't be so aggressive to obtain a blood glucose control. But we usually start insulin analogs, and in fact, when we treat initially a kidney transplant recipient, we use a lot Dpp4 inhibitors. Like, they are very easy to use without adverse events, and like it's very comfortable for the patient and also for us.
I have a question. You don't have adverse events, but you do not have beneficial events. So you don't know. So are you planning in a future maybe to modify your strategy?
Well, in fact, we also use GLP-1 agonists. Initially, we don't treat with SGLT2 inhibitors, like because of the changes of glomerular filtration rate. But it's not only in terms of the use of Dpp4, it's not only the fact that you decrease or improve metabolic control. It's also like the beta cell, try to not stress the beta cell function, like try to maintain its function till the end of the transplantation. There are some studies that are studying using this drug to prevent the appearance of post-transplant diabetes mellitus, and that's why we use this drug now, not only for controlling metabolic glucose, but also for trying to decrease the needs of insulin long term.
And Sankar, what do the guidelines say? I know you're involved with Cadigo, but you also know the other guidelines. What do the other guidelines recommend? Are they Dpp4 inhibitor fans?
Right. So just to refresh everyone's memory, that there is a dedicated Cadigo guidelines for kidney transplant management. That was published in 2010, and I think that's due for update, and Cadigo team is working on it. So the most recent Cadigo guidelines for diabetes and kidney disease management specifically excluded making a recommendation for transplant population for the following reason. It is not simple, straightforward that you just only add a medication to control diabetes, but you got to also may need to change some immunosuppressive agents. So that was the reason that why in the current Cadigo, recently released Cadigo guidelines, we didn't touch upon that part. But coming back to what Dr. Montero pointed out, that the management, I think, is going to depend on what when they develop the diabetes, post-transplant diabetes, and what's their level of kidney function. So that would, to some extent, dictate the agents of choice. I'll not go into that in detail, but just wanted to also point out, since you brought out the guideline. So there is a UK-based guideline from the Renal Association and from the UK Diabetes Group, which actually does recommend metformin, especially if they have preserved kidney function, as the first line of agent to manage diabetes, post-transplant diabetes. So
I think that's a demonstration of when you don't have large-scale, clear randomized evidence, everyone interprets the evidence slightly differently and comes to a slightly different conclusion. It's pretty remarkable. So, Sankar, what do you do in your practice? Do you treat many people with post-transplant diabetes?
So with respect to the post-transplant diabetes, I think, as I mentioned, like if they are earlier on, if they develop something within 3 to 6 months, or around within less than a year, you want to start managing with insulin if you can, to see as you taper down the steroids and you get them back to the lowest possible range. Are the other agents that we lean on to is like sulfonylureas or Dpp4 inhibitors. So, those are the agents that we lean on.
I don't know if either of you might want to answer this question. It was quite striking from one of the slides. We see the GLP-1 agonists, they seem to have an albuminuria lowering effect. I've never been convinced that it clearly leads to reductions in risk of kidney disease progression or end-stage kidney disease. And then the Dpp4 inhibitors, we've got Carmelina, which shows almost zero effect on risk of progression, and much more modest effects on albuminuria, but aren't they targeting the same pathway? Is there what might be the reason for the difference between the two? And might we ought to be thinking about using more agonists from the GLP-1 pathway than Dpp4 inhibitors in post-transplant diabetes as a result of these sort of subtle renal differences?
I think that perhaps it's because of the increased effect of lowering weight of GLP-1 receptor agonists. I think that if you control weight, like they can lose a medium of 2 kilos, and that's a lot. And then it's easier to decrease albuminuria related to obesity. So that I think that this is the main difference. I don't know if Dr. Navaneethan have any other comment.
Yeah, so regarding Dr. Herrington's comment on GLP-1 data on proteinuria, if you look at the leader, one of the largest trial, the composite outcome was better with GLP-1 receptor agonists, but it was predominantly driven by the proteinuria component. So we have some large trials that are ongoing in the general CKD population, but we don't have anything, as you pointed out, that elegant, tables that unfortunately we don't have any data. Why would we not prefer GLP-1 over Dpp4 inhibitors? One of the concerns I think you did point out in the slide is like adverse effects. The GI tolerance could be an issue when they are used with the mycophenolate mofetil. But the benefit of weight loss, again, GLP-1 has received recently, one of the agents has received FDA approval for weight loss as an agent for weight loss. So that's an important component, if these people have gained weight of the transplant population. So that's one other reason to go for GLP-1 than Dpp4.
Actually, I've seen one non-transplanted patient that lost 16 kilos. Actually, I was thinking about, is this patient having a cancer? And this is after starting GLP-1 agonist. So he told me, doctor, I really lost a lot of weight. And I was, let me check, let me realize, and you started 16. So do you think that in the future, it will be a place for the obesity patients after kidney transplant with steroids?
Well, I suppose that it's a good drug for them. I think that the main problem in these patients are gastrointestinal adverse events, and I'm using these agents now out of the record, and the main problems are that they really have gastrointestinal adverse effects, and that are quite difficult to manage. Well, you can decrease the dose of the GLP-1 receptor agonists, but then they also lose their effect. So it's quite difficult to manage.
Interesting. So, so SGLT2 inhibitors, the Halden trial, you know, they don't seem to be particularly effective at lowering HbA1c in transplant populations, but we go to them in CKD now because of their reduction in risk. So it's a real shame we haven't got more randomized evidence in the transplant population. Could you just remind us a bit about the UTI risk? Because I know we're looking at all of the big trials. It's only been since we had 11 of the large trials report that we can now identify an increased risk of UTI. So we've been doing a meta-analysis recently, and it's now only just after 5,000 serious UTIs, we see about a 7% increased risk of UTI with SGLT2 inhibition compared to placebo. 7, much lower than I was expecting given their mechanism of action. And before Emperor preserved, the results were not quite positive. So it needed 11 massive trials to identify this tiny effect. It's clearly effects on mycotic infections and thrush. So is there real risk in the transplant populations? I know transplant patients want to do anything to risk their kidneys, but if they've got preserved kidney function and we really want to modify their cardiovascular risk, how much do we have to be afraid of the UTI risk in transplant patients? Do we know?
It's an important question, you know. Well, I think, you know, the question is, the risk of UTI is much higher in transplant population compared to the general population, right? So with the SGL2, if there's a 7% increased risk in the general population, would that be the same, or would that be double, triple? In the transplant, more than likely to be higher, if I have to bet. That said, if ultimately, unfortunately, the patients die of cardiovascular disease, or, you know, they have chronic graft loss, they may go back to dialysis, unfortunately. So modifying that cardiovascular risk is the key one. So for that reason, yes, SGLT2, you know, inhibitors, after discussions with the patient, explaining them the side effects, I think the nephrologists overall are getting used to using these medications comfortably, starting these medications. But that might need another notch up, meaning like you got to explain to the transplant population, which most of them are, you know, able to get it, follow the recommendations, explain them the risk of UTI before you start SGLT2 inhibitors, which is, as I said, like it's going to be likely to be higher than the general population.
I mean, I think recurrent diabetic nephropathy in a graft might be a good subpopulation to start thinking about a trial, if not all patients with the transplant. So I've got a good question here from Francis Sandergon. He just wants a nice summary of clear do's and I think perhaps don'ts in diabetes management after transplantation. Are there clear don'ts? Things you mustn't do or you would advise avoiding at all costs?
Well, in fact, it's like don'ts. I think that you have to be really take care of the patient and like know which patient are you treating. For example, another time, we are now transplanting very elderly patients, very fragile patients. So you have to be really aware of not starting an insulin analog without explaining how to manage that, how to manage hypoglycemia. So you have to be really aware that kidney transplant is a challenging situation. You are changing GFR, you are changing its appetite, you have a lot of infections and concurring problems. So you have to be monitor it very closely and educate the patient a lot. I think that and using insulin analogs, you have to like take care of these patients very well.
Yeah, I agree. The one other thing is like reaching out to other specialties for help as needed, right? We all practice in different settings where we may have different access to, you know, the access to resources could be different. But if we are using insulin analogs, then it may be a time where you may want to engage endocrine colleagues. We don't want them to manage our transplant medications. So sometimes you just want to get the appropriate help and a multidisciplinary approach could go a long way, which is again recommended in the Cadigo diabetes guidelines.
And Ismail Dursun has asked whether or not there's any evidence in pediatric transplant patients for what to do. I guess you're both adult nephrologists, but did you come across anything from pediatric literature?
I must confess that I haven't looked at it specially, but I don't think so.
Yeah, I'm pretty sure we've looked at the SGLT2 literature, and there's virtually nothing in pediatrics to cover that, with these novel agents there, unfortunately, have been left out.
Yeah.
So I was actually had a look at the Holden data for the SGLT2 inhibitors, just as we were talking there. It was 3 UTIs in the empagliflozin group and 3 in the placebo group, 1 severe urosepsis in the empagliflozin group. So yes, there is a risk there, because there was only 44 patients in the trial, and they identified 1 serious urosepsis amongst 22. So I think it is high time we had some decent trials. And Maria, you noticed there are some trials ongoing on clinicaltrials.gov.
Yes, we were commented previously. They are now currently some trials, mainly with dapagliflozin and with empagliflozin, that they will finish around 2024. So we will have more data on that. And I think that in 4 years ago, maybe we will know how to deal with these drugs. Actually, another good point of this couple of new drugs are that they don't provoke a lot of hypoglycemia. So this is another point that in the future may be helpful. Maybe in patients with kidney transplant, it will be better not to start at the first moment where the urinary tract infection is more frequent and start 1 year later. I don't know. These are only, I am only thinking out loud, but maybe this could be some changes in the future. I don't know.
And has anyone seen any trials? Because there's a question here from Yanak de Zoyse about using these agents before you get diabetes in people who are at risk, maybe to try and prevent that.
Yeah, I've noticed that in clinicaltrials.gov, there are 3 clinical trials that are going to use Dpp4 inhibitors to try to avoid the appearance of post-transplant diabetes mellitus. I think that that's really, really interesting, just to lower a little bit the incidence, because it's like 50% of all transplant population is a great incidence.
It seems to me that there's a group in Oslo that seem to be doing all of the single-center trials of these agents. They've done, it's the Halden team have done the Dpp4 and the early GLP-1 agonist trials, and then also the more recent empagliflozin trial. Why isn't it the transplant teams are doing multi-center trials of these novel agents earlier? Is there do you have any idea why we haven't got large-scale trials in transplantation and they're being sort of, as a population, neglected?
I think it's just a matter of time. We're doing trials in non-diabetic CKD population, right? I mean, we're now IgA nephropathy, FSGS, and other conditions for which they're exploring SGL2. I think it's just going to be a matter of time that probably this would come up soon. I agree that I'm just looking at the Cochrane meta-analysis that was published last year. It had only like 10 studies in transplant population, clinical trials on glucose lowering agents. So begs the question, the transplant investigators that this is a high time to look into these drugs.
Yeah, I mean, we still suffer from chronic allograft nephropathy. And you do wonder whether or not, in particular, SGLT2 inhibitors have been shown to be so effective in people who are hyperfiltering with albuminuric kidney diseases. Maybe when you start to get transplant glomerulopathies, or indeed any recurrent disease, whether or not we should be thinking about these agents, because the risk of graft loss starts to increase. And so the balance of benefits and risks may well start to head towards favor of benefit, and so exciting times for nephrology. Sankar, were there any questions you wanted to ask Nuria whilst we've got her on the stage?
What is your experience, Dr. Montero, with respect to using the common medications, metformin and sulfonylureas? They are the cheapest and widely available, less expensive for many resource restrained countries, it is a key issue.
Well, we use metformin really usually, but only after 1 year post-transplant, just to have a stable glomerular filtration rate. But it's also difficult to have a kidney transplant recipient with a very good renal function. Like the most of our patients have a glomerular filtration rate below 30. Then it's not possible to use metformin. Sulfonylureas are really used, and I think that most of us use these molecules. But another time, it's like when the recipient is stable and without problems, like after 1 year of transplantation, that you can use them like comfortably without any risks.
Yeah, that's our approach as well. Another clinical question always comes up is like, what's your target? Are you aggressive? Do you treat a transplant patient as a general population, like targeting 6.5 to 7? Are you a little bit lenient going with Cadigo for the non-dialysis CKD 7.5? What's your threshold?
Well, my colleagues say that I'm like very strict with my patients, my diabetic patients. And yeah, I am. I confess that. I like to have them below 7, but another time it depends of the patient because like very old patients, more than 75 years old or 70 years old, depending on the patient. And in that case, I will target below 8. So it depends on the patient. But yes, I confess I'm like a little strict with my patients.
And your target, Dr. Sankar?
We used to be targeting 6.5 to 7. So I have to say, we started individualizing. And that's, if you look at the nice a figure that actually we adapted from ADA, showing like who you want to have a strict control, a young patient who has a long longevity, who can recognize hypoglycemic episodes. You want to be more aggressive around 6.5. Older adult who probably polypharmacy, which is common in transplant setting. Then we try to give them a little leeway, 7s, maybe even up to 7.5 sometimes, but right around 7, I would say.
Which is the worst medication out of the novel agents for upsetting tacrolimus and cyclosporin levels? You mentioned quite a few interactions in there. Do you see meaningful changes in these concentrations, or are they things that are easy to cope with?
Well, you have to be aware just to make a blood control, a blood glucose monitor of the levels probably more frequently. So when you start these agents, you have to do a blood control in 15 days after the initiation of the drug. So if you are aware of that, no problem, but you have to be aware of that, because if not, you can like promote a rejection. So you have to be really aware of that. 15
days. Okay, that's a good instruction.
Right. I mean, and educating the patient, because we may not be the only one who might start these medication. They may be seeing a primary care physician or another specialist. So educate the patient that if somebody is adding a new medication, please let us know.
And that's a really important point, isn't it? Okay. I'm all out of questions, and I think we've covered all of the questions in the chat. Were there any final comments or questions from anyone on the panel before I wrap up?
No, I think, as you noted, Bill, I mean, we need more clinical trials, and it takes, a few years to complete these trials, especially if we are looking for outcome-driven trials. But meanwhile, we got to manage our patients. So we have experience from non-transplant population, those with CKD, for all these medications, thankfully. So if we have to apply these data and following Dr. Montero's like nice tables, we got to be cautious, but we may try different agents according to their risk profile on these medications. And the other thing is, for research purposes, I don't know if there is an opportunity to generate some real world data, despite that these are not clinical trial, but assembling these case series or case series might not go a long way, but maybe from large databases, insurance providers databases, there may be an opportunity to generate some real world evidence.
I am interested in that as a concept. I mean, I'm very skeptical about these types of data, but if we're not going to have any data, whether or not it's better to have a look. And I think if you do look in incredibly large databases and you pre-specify it, and we're really looking for safety, so large effects on, for example, kidney infections. If you want to see what the rate of UTI is in people treated with an SGLT2 inhibitor, those types of databases might be interesting to reveal. I'm very skeptical, I have to say, Nuria, about case series. There was almost certainly going to be a publication bias. You know, people who find very few UTIs in their cohort, well, that's very interesting, we'll publish that. They find quite a few UTIs and may think twice. So yes, so I think that is an interesting concept, Sankar. And it's a shame that transplantation is having to turn to that as a concept, but with registries and routine data available to them, it would be very useful to raise hypotheses. Yeah.
I have a question. Do you think that these drugs have any place in the waiting list before kidney transplant?
Oh, yeah.
For example, GLP-1 agonists. If you lose weight and you go to kidney transplant with less weight, it will be better, no? What's your opinion? It's for both of you, the question.
Can you repeat that, Dr. Soler?
If GLP-1 agonists, they have a weight in the waiting list. They have a place in the waiting list.
For management of diabetes, right? So
yes,
if they are on dialysis, and would you put them on these medications?
Or obesity in the future?
I don't know. We don't have, I'm not aware of any data. I don't know if Dr. Montero, if you have come across. I mean, this is essentially preventing.
Yeah, in fact, I think that it will be really useful. I think that probably the use of these agents in the waiting list can promote weight loss. So if you reduce obesity in these potential recipients, probably kidney results would be better also. But what I'm really aware of is that these agents, I think that there's one study that's it's now taking place in Europe, if I'm correct, that they are using the GLP-1 receptor agonist in the donors, in donors with obesity, just to improve their results, to reduce body weight.
I think Maria's point is very interesting, isn't it? We've talked all about post-transplant diabetes, but what about treating them once they've developed it? But if you can get their weight down before they were transplanted, yes, there's the TIME trial, wasn't there? TIME-1 trial with semaglutide, which is very impressive. And I know that there is more trials with semaglutide. There's a TIME-3, which is actually very large, 17,000 patients, and has got a renal progression outcome. So it's possible that if we catch them early enough with these drugs, we may even get their obesity levels down and maybe even prevent their progression to end stage. Anyway, so great. Okay, well, that's been fabulous talk. We've gone well beyond post-transplant diabetes into the potential of the future. I've learned there's a lot of case series out there in transplantation and not enough trials, but we've been told we need to be patient because Maria and Sankar know that there are trials coming. So in the next couple of years, the management and these guidelines may be more consistent because there's a decent evidence base. I'm really grateful to you all for coming to contribute your insights today. Please do go to the CKJ website and read Nuria's review. Please do also check out the website. There are plenty of other papers. There's a lot on SGLT2 inhibitors. Maria has published with Alberto Ortiz on SGLT2 inhibitors in non-diabetic kidney disease. I've just put a shameless plug for the kidney rationale paper in the chat. But next week, we're going to move well away from diabetes. We're going to move away from transplantation. So next month, and on Thursday, the 25th of November, we'll be discussing monitoring of anti-PLA2R antibodies in membranous nephropathy with another team from Spain. We're going to get comments from UK a nephrologist with a key interest in a membranous, so Arif Quadra and Megan Griffiths, but also the working group member of the Cadigo Glomerular Guideline, Dr. Mahia Ville from Mexico. So I'm really looking forward to that. And thanks again to Nuria, Sankar and Maria, and we'll see you in a month's time.